Greetings! Welcome to the Newborn Resuscitation video lecture. Later, you will be having a small group discussion regarding this topic. I am Dr. Wilfredo Santos, a newborn medicine specialist. Baby boy W was born to a 35-year-old Gravida 1 Para 1 school teacher with gestational diabetes and pregnancy-induced hypertension. She is a non-smoker, non-alcoholic beverage drinker with 10 times prenatal checkup with an obstetrician. Hepatitis B and HIV screening were normal. A few hours prior to delivery, she experienced severe abdominal pain and was immediately brought to the emergency room. Fetal monitoring at that time revealed fetal bradycardia. Thus, emergency cesarean section was done because of abruptio placenta. She delivered to a male newborn with maturity index of 37 to 38 weeks age of gestation, birth weight of 3.2 kilograms, and a birth length of 52 centimeters. Apgar score was 0, 1, 3, 5, 7 at 1, 5, 10, 15, and 20 minutes respectively. The baby was immediately intubated at birth, initially placed on positive pressure ventilation, then on mechanical ventilator. Most newborns will not require immediate resuscitation at birth, but there are about 10% who will need assisted ventilation because of the following conditions. Maternal conditions like obstetric complications, infections, drugs. Fetal complications like congenital anomalies, and neonatal complications like congenital anomalies, infections, and maternal drugs. The following are the steps in newborn resuscitation, delineated as A, B, C, D: A for airway, B for breathing, C for circulation, and D for drugs. For airway, during neonatal resuscitation, be sure that the airway of the baby is patent by placing him or her in a slightly extended neck position, or what we call as the sniffing position. This position will align the glottis and the trachea so that the patency of the airways can be maintained. No need to suction with a wall suction machine. If there will be too much secretions on the mouth, nose, and oropharynx, use a bulb syringe to suction the mouth, then the nose, to prevent aspiration of the secretions. For breathing, once the baby is delivered, observe for respiration and muscle tone. If the baby is gasping or not breathing, do positive pressure ventilation or PPV for 30 seconds. Then assess the heart rate, color, and respiration. Place the baby on a pulse oximeter to determine the oxygen saturation in the blood at 10 minutes of life. The neonate should only have an oxygen saturation of 80 to 95% using the positive pressure ventilation. If after 30 seconds of positive pressure ventilation, the heart rate is more than 100 beats per minute with good respiration and the baby is turning pink, stop the PPV and administer blow-by oxygen with a face mask at 5 liters per minute. Then observe the baby. Do positive pressure ventilation as follows. Breathe, squeeze the ambu bag. 2-3, releasing the ambu bag. There should be 40 to 60 breaths per minute. So you do it as breathe 2-3, breathe 2-3, breathe 2-3. For circulation, if after 30 seconds of positive pressure ventilation and the heart rate is less than 100 but more than 60 beats per minute, then continue your positive pressure ventilation for 30 seconds. But if the heart rate is less than 60 beats per minute, even with continuous positive pressure ventilation, consider doing endotracheal intubation and start doing your chest compression. There are two ways of doing chest compression, the two-finger technique and the two-thumb technique. The landmarks are an imaginary line between the two nipples and just above the xiphoid process. PPV should be done simultaneously with your chest compression. There should be two resuscitators by this time. The sequence should be 1 positive pressure ventilation per 3 chest compression. So it should be 1 and 2 and 3 doing your chest compression, and then breathe doing your PPB. So the cadence should be 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Endotracheal intubation can be done at any time if there is a need to do so. After 30 seconds of chest compression and positive pressure ventilation, assess the baby's heart rate, respiration and color, and oxygen saturation through the pulse oximeter. If the heart rate is more than 100 beats per minute, stop your chest compression and positive pressure ventilation and give blow-by oxygen. Observe poor oxygen saturation. It should be more than 90% saturation of oxygen. Then monitor the baby's vital signs. For drugs, if the baby is not responding to your chest compression and your positive pressure ventilation, the heart rate is less than 60 beats per minute, give epinephrine through the trachea if the baby is already intubated, or umbilical vein catheter if umbilical vein catheterization was done already, and this should be placed during the resuscitation. If after giving epinephrine, the baby's condition is not improving, check for pneumothorax or air leaks, check for equipment failure, or the need to give volume expanders like press whole blood if there was blood loss, press frozen plasma, or colloid solutions. Monitor the baby every 15 minutes until the baby is stable and place on mechanical ventilator. After resuscitation care, if the baby is still intubated and needs to be placed on mechanical ventilator, transfer the baby to the neonatal intensive care unit or NICU and monitor the following: the vital signs, temperature, the blood pressure, capillary blood glucose, place an IV fluid, monitor the serum electrolytes, your sodium, potassium, and your calcium, and arterial blood gases. You should also administer the following: parenteral nutrition, because you have to place the patient on nothing per ORM temporarily, or inotropic agents like your dopamine and dobutamine to help the contractility of the heart. And since you have done some manipulation to the baby and intubation, antibiotics is warranted to be administered. Thank you.